welcome to The Code Tray, the podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP EMED-PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
So now we have Gabbi Ford, who is a PGY2 emergency medicine resident at UW Health. Today, she will be presenting a journal club on naloxone and patient outcomes in out-of-hospital cardiac arrests in California. Thank you.
Before we get started, I just want to say that I don't have any potential conflicts of interest related to the content of this presentation that I needed to disclose. For a bit of an overview, I'll just start with some background, and then we'll really get into the methodology of the journal club, as well as results, discussion, and then ultimately a conclusion. To start off with some background, really to just define what is an opioid-associated out-of-hospital cardiac arrest. So the American Heart Association defines that as any out-of-hospital cardiac arrest that is precipitated by the use of opioids with or without any co-intoxicants. So essentially, it's a little bit different than what we would think about as a standard out-of-hospital cardiac arrest. It's more of this gradual progression to that. So we have these patients who start off with hypopnea, hypoxia, ultimately leading to this decrease in cardiac output, hypotension, bradycardia, and then ultimately cardiac arrest. So this is a little bit different where we have a little bit maybe more time than we would see in these sudden events like arrhythmia-induced cardiac arrest. So maybe leaving some room to where we have this opportunity for a targeted rescue, such as assisted ventilation, or obviously what we're going to talk about today, which is naloxone. Currently, opioid overdose is the leading cause of death for Americans between the age of 25 to 64 years old, and is the leading cause of cardiac arrest due to poisoning in North America. It accounts for about 6 to 14% of out-of-hospital cardiac arrest. Previously in 2021, AHA recommendations stated that if an opioid overdose was suspected, naloxone could be considered. However, up until pretty much this year, there weren't really any studies that demonstrated any kind of improvement in patient outcomes from administration during cardiac arrest specifically. We know that it benefits patients that are not in cardiac arrest that have overdose, but specifically once patients have progressed to the cardiac arrest phase. And then this is just a diagram that essentially is showing the incidence of opioid-associated out-of-hospital cardiac arrests in the context of all overdose deaths and naloxone use. So over here on the left, we have our entirety of overdose deaths, and then further progressing specifically to opioid-associated ones. And then on the right, we have the incidence of EMS administering naloxone, and specifically also coming down to related to opioid overdose, and then the little tiny portion down there specific to EMS treating opioid-associated out-of-hospital cardiac arrest, and how many of those actually survived a hospital discharge. So very, very small in comparison to the amount of overdose deaths that we see, and then as much as EMS administers naloxone. So there were some other related literature that came out actually this year as well. So the one on the left, Strong et al., briefly in May of 2024, so before this one came out, it was an EMS database retrospective cohort study. It had about 1,800 non-traumatic, non-shockable out-of-hospital cardiac arrests. They were looking at essentially if giving naloxone early, so prior to any kind of access versus after access, or not at all. They really saw that younger males were a lot more likely to receive naloxone, but they actually did see some significance in survival to hospital admission and discharge, and with good neurologic outcomes. And then on the right, we have Quinn et al. That came out later in 2024 in September. It included about 800 out-of-hospital cardiac arrest patients, and with 175 of those receiving naloxone. Again, they saw that patients who received naloxone were a lot younger, they had less comorbidities, and this is a theme that we'll see with the study today as well. But this study actually saw no difference between naloxone or the standard of care group. And then last year, the AHA released some focused updates on the management of patients with cardiac arrest or life-threatening toxicity due to poisoning. And they specifically released a statement saying that for patients that are known or suspected to be in cardiac arrest in the absence of proven benefit from naloxone, Standard resuscitative measures should take priority over naloxone administration with a focus on high quality CPR. And this was a strong expert opinion recommendation, essentially saying that you could, again, consider giving naloxone. It can be administered along with standard of care, but not letting the idea of that hinder any kind of components of high quality CPR and the things that we know that actually save people's lives at the end of the day. I know all of us are very, I'm sure, well versed in naloxone, but just briefly, it is a mu opioid receptor antagonist. There are a lot of different routes that you can give it through: IV, IM, IN, or sub-Q. However, the dosing is a little bit different. So if you're doing IV, IM, or sub-Q, it's 0.04 to 2 mg, but intranasal is going to be that 4 to 8 milligrams. There are pretty few risks to giving naloxone in general, but just being aware that there has been some associated pulmonary edema and cardiovascular instability. So they've been reported in association with abrupt onset of reversal with opioid antagonists. So just kind of something to be aware of as we're considering it in this patient population. Now I'll dive directly into the journal club. So looking at naloxone and patient outcomes in out-of-hospital cardiac arrest in California. The main objective of the study was really to evaluate the association of naloxone with clinical outcomes in patients with undifferentiated out-of-hospital cardiac arrest. Again, we know it's been seen to be beneficial in patients in drug overdose, but without concurrent cardiac arrest. So really looking at, does it have any role in patients that progress to cardiac arrest? For the study design, it is a retrospective cohort study. It included 3 Northern California counties from 2015 to 2023. For the population, these patients were greater than 18 years of age, and they received EMS treatment for non-traumatic out-of-hospital cardiac arrest. The exposure that they looked at here was EMS administration of naloxone that is verified by the medication administration record. For methodology, patients got excluded if they were less than 18 years old, or if there was any kind of naloxone administration information that was missing, so they couldn't really tell if patients got it or not, or it wasn't clearly documented. Our exposed group, as mentioned, received naloxone. The control group did not. There were several covariates that were included, like age, sex, initial cardiac rhythm, lots of comorbidities if the arrest was witnessed, and if it was considered a drug-related cause of arrest. They defined that as being caused by a known or presumed overdose of legal or illegal substances. And this was really just determined on a case-by-case basis by EMS if they were calling it drug-related or not. For statistical analysis, very, very intricate and pretty complicated. I'll try to briefly go over it, but without diving in too deeply. So essentially, they used a logistic regression model to analyze the data and include the variables. Also, they used these 2 propensity score models to reduce the risk of selection bias. So those were the inverse probability weighted regression adjustment and then the nearest neighbor propensity score matching. These are very, very convoluted and intricate, as mentioned, but essentially using these, they really just saw more consistent data that they already saw in the non-adjusted group. So it only really kind of helped to confirm any data that they saw previously. And then also there was 2 sets of additional analysis that got performed. So they examined the average treatment effect on the treated patients and then a mixed effect regression model using covariates to include an interaction of naloxone administration and presumed drug-related out-of-hospital cardiac arrest. The outcome measures that they're looking at, so for a primary outcome, they're looking at survival at hospital discharge, and then for a secondary outcome, looking at sustained ROSC. So they defined that as having a detectable pulse for at least 20 minutes at the end of EMS care. For patient cohorts, there was a little over 8,300 medical records that got identified and only ended up excluding 144, most being for age, so less than 18 years old. And very few actually had incomplete exposure data that got excluded. Just under 8,200 out-of-hospital cardiac arrest events in total were included, and then 1,165 of those patients ended up actually receiving naloxone. Something really important to note in the study is that the baseline characteristics between the 2 groups are very, very different, and as well as some of their cardiac arrest characteristics. I really just tried to pull out the most profound ones and just really ones that I felt like added value to why we should consider why these groups were so different. So looking at the ages, Our naloxone group was a lot younger, so a median of 46 years old versus no naloxone of 67 years old. We had a lot more males that were present in the naloxone group, way less comorbidities in the naloxone group as well, as we saw in the previous two studies that I talked about. The naloxone group arrest location was a higher percentage of on the street. And as far as a witnessed arrest, it was overall fairly similar between both of the groups, 45% versus 56%. For presumed cause of drug-related, obviously the group that received naloxone, that was a lot higher, so about 40%. Also, there was presumed cause drug-related in the no naloxone group, so a little bit interesting to consider maybe why these patients didn't receive naloxone at all. And then ones that were not drug-related, even about 60% of those did end up receiving naloxone. So just something kind of important to remember as we dig into the results too. Looking at the next set of results, so the odds of a patient receiving naloxone. So obviously, if it was presumed drug-related, their odds to receive naloxone are much, much higher. But then looking down further, so age really had no difference in odds for the groups, but male sex and having a non-shockable rhythm had a higher odds ratio of receiving naloxone, as well as any unwitnessed out-of-hospital cardiac arrest. So very interesting that also comorbidities and age weren't really associated with an increased odds of receiving naloxone. For our primary and secondary outcomes, we look first at sustained ROSC. So in our naloxone group, we see that sustained ROSC occurred in about 34.5% of the groups versus 22.9% in the no naloxone group. Patients in the naloxone group were 45% that got admitted to the hospital from the ED, and only about 31% in the no naloxone group. And then looking at discharge from hospital, as a whole, only 10.6% of this entire patient population got discharged from the hospital. So just kind of proving further that really the prognosis after out-of-hospital cardiac arrest continues to remain pretty poor regardless. But we did see in our naloxone group, almost 16% ended up getting discharged from the hospital versus 9.7% in the no naloxone group. To really summarize those outcomes and the association with EMS administration of naloxone, we saw that 3.9 percentage point absolute increase in survival to discharge. So coming out to a number needed to treat of about 26 in that patient population. And then for the secondary outcome, we saw an 11.8 percentage point absolute increase in ROSC with a number needed to treat of 9. As far as the author's conclusions, in general, suggest that the benefit of liberal naloxone use would likely be more pronounced in communities that already had a higher underlying risk of drug-related out-of-hospital cardiac arrest, which makes sense. They also saw an observed weak association between naloxone and improved clinical outcomes in non-drug-related out-of-hospital cardiac arrest, which I thought was fairly interesting. And then EMS-administered naloxone was associated with clinically significant improvements in ROSC and survival to hospital discharge. However, really, prospective trials would be needed in the future to offer any more definitive evidence regarding the use of empiric naloxone in these non-traumatic out-of-hospital cardiac arrest events. However, I think the rising incidence of opioid-associated out-of-hospital cardiac arrest events, as well as current findings that we're seeing, might be convincing enough to encourage early naloxone administration, even in these populations, especially when we're seeing that they already have a higher opioid incidence rate. So maybe depending on which population you're in, it might be, a better situation to consider giving naloxone a little bit earlier. For the strengths and limitations of this study, I think as far as strengths, it was generalizable to a lot of pre-hospital settings, especially when we rarely ever know what the cause of arrest is. And then it also had a really adequate sample size, I thought. Obviously, our naloxone group was a lot smaller, but still having over 8,000 cases was pretty strong. For limitations, it had no report of naloxone dose or route or what time it was given during cardiac arrest, which would be really important to know. And, does it matter how much we give? Does it matter which route it is? Does it matter if we give it early versus late in cardiac arrest? And then also, as mentioned already, the baseline characteristics were really, really different. So the naloxone group was younger with less comorbidities. Again, we have no follow-up for improved functional outcomes of survivors. So sure, we had an increase in survival to hospital discharge, but does that actually mean anything for the quality of life for these patients? And then also the location of EMS agencies and the baseline drug-related encounters that they already have. So maybe, I wouldn't know for sure, but maybe you could consider that where this study took place, there was already much higher incidence of drug-related encounters. So thinking about that when considering how it could be generalizable to maybe a population that isn't known for as many drug-related cardiac arrests. Some key takeaways to consider are that it's difficult to conclude if naloxone alone is responsible for these better outcomes in patients experiencing out-of-hospital cardiac arrest. And as mentioned, we really need those future studies to control for naloxone dose and the timing of administration during cardiac arrest. Ultimately, though, a big takeaway is that the use of naloxone should not precede any kind of other ACLS interventions, such as ventilation and CPR, even when it's highly suspicious of opioid-associated out-of-hospital cardiac arrest. ACLS guidelines should still be followed regardless, and at the current time, there's no recommendation to stop any kind of ACLS algorithm and give naloxone instead. So still continuing to follow what our ACLS protocols have for us. And I wanted to thank my program director, Joe Halfpat, for his contributions to this presentation. And with that, I'll take any questions.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.